Hello, and welcome to the Johns Hopkins Pandemic Data Initiative's 5th Expert Forum. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, Vice Provost for Interdisciplinary Initiatives, and a leader within the Johns Hopkins Coronavirus Resource Center. Today, we'll focus on the exciting opportunity available for the United States to build upon the vast amount of public health data collecting and sharing that has been developed during the pandemic through investments at the local, state, and federal levels. We'll explore the ways this new infrastructure can be recast and cemented as a permanent fixture for disease surveillance and for tracking equitable healthcare access moving forward. 2 years ago, Johns Hopkins launched the Coronavirus Resource Center to collect, report, and analyze COVID-19 data from local, state, and federal government agencies in the United States and around the world. Millions know us for the global map that provides real-time data visualizations of the pandemic. The overwhelming positive response and traffic for this first-of-its-kind effort revealed just how critical this data is and how much interest the public has in data to inform important decisions in their daily lives. But our work has also revealed a major shortcoming. Everyone interprets and manages this data differently. And that's what inspired us to start the Pandemic Data Initiative. Our goal with the PDI is to highlight all of the lessons surrounding public health data that we have learned from the COVID-19 pandemic. We're especially interested in how we can best prepare data infrastructure to spot future health crises earlier and manage them better. Today will be an important step towards this goal as we discuss some of the lessons learned during this pandemic. This is the 5th of several forums we plan to host to discuss what worked in COVID-19 public data management, what did not work, and how to improve moving forward. As part of today's forum, we'll have an opportunity for Q&A with our speakers. Please submit questions for our experts in the window that you'll see at the bottom of your screen. I'm now going to introduce our panelists. I'm joined today by 4 guests who will share how COVID-19 data tracking systems can shape a more efficient and effective global response to future public health crises among policymakers, researchers, and government entities. Amanda Daflos is the inaugural executive director of the Bloomberg Center for Public Innovation at Johns Hopkins University. She previously served as the Chief Innovation Officer for the City of Los Angeles. Prior to that, she served as director of Mayor Eric Garcetti's Innovation Team, or I-Team, and oversaw Mayor Garcetti's gender equity agenda, which achieved substantial results across city government, has been replicated by numerous cities, and led Change, a city network dedicated to implementing outcome-based equity programming globally. Next, we'll hear from Mayor Greg Fischer, who was elected Louisville's 50th mayor in 2010 and was sworn in for a third 4-year term on January 5th, 2019. Governing Magazine named Mayor Fischer Public Official of the Year in 2013. A 2016 Politico survey named him the most innovative mayor in America. And in 2017, Politico named Mayor Fischer among its list of the nation's most interesting mayors. In 2020, America's mayors elected him to serve a 1-year term as president of the non-partisan U.S. Conference of Mayors. Then I'll turn to Dr. Sarah Kemble. She is the state epidemiologist for the Hawaii Department of Health and chief of the Disease Outbreak Control Division. Born and raised in Honolulu, Dr. Kemble completed her residency in internal medicine and pediatrics at UCLA and infectious disease fellowship at Rush University Medical Center in Chicago, Illinois. She's an alumna of the Epidemic Intelligence Service Fellowship Program at the Centers for Disease Control and Prevention, during which she was assigned as a field officer at the Minnesota Department of Health. She previously served as medical director for the Communicable Disease Program at the Chicago Department of Public Health. Finally, we'll hear from Dr. Sean Truelove, an assistant scientist and infectious disease epidemiologist and disease modeler at the Johns Hopkins Bloomberg School of Public Health in the Departments of International Health and Epidemiology. He specializes in applying infectious disease dynamics and modeling for direct public health response, decision-making, and policy. He's also a core faculty member of the Johns Hopkins Infectious Disease Dynamics Group and has been deeply engaged in the public health response since the beginning of the SARS-CoV-2 pandemic. Thank you all for joining me today. Amanda, I'll now turn to you for an overview of how COVID-19 has changed the data landscape and what that means as we move forward.
Dr. Rutkow, thank you so much for the introduction. And of course, it's a pleasure to be here alongside all of the other speakers. I think today's session is really an important session because it comes at a moment in time when we are hopefully soon to move to the endemic stage of COVID-19. And it comes at a moment when cities and states and the federal government may be asking the question about how data can be useful from here forward. And it comes at a moment when we ultimately have a discussion to have around how data has really transformed lives over the last several years through COVID-19 and what things could look like as we go forward. And it's an important moment. It's a moment where we get to make a choice. And one of the things I think that's happened over the last several years, if you think back to 2019, pre-COVID-19, there were very few things where people use data to really govern their lives. And one of the things that, of course, the JHU dashboard and then individual cities, the states, and the federal government did through all this data work was transition people into thinking about life in data. We thought about how many cases there were, how many deaths there were, how many hospitalizations there were, and that governed policy as much as it did individual daily choices about to wear a mask, to see friends, to even go to the grocery store. And so I think the question becomes, what else in our lives, maybe only sports. Sports, at least in the US, is something where we think, certainly in data, and we experience something that we love that's actually quite close to people's lives through data. That's maybe one of the only places where we think about baseball and we think about people in numbers. It really becomes a question of what is now the power and what can we do given all the amazing work that's actually happened through municipal and through wider government organizations, and then organizations like Johns Hopkins and the Coronavirus Resource Center. And it seems that one of the other important opportunities, not only that piece, but one of the other important opportunities that's come about is this idea that we've learned a lot about our communities based on the data we've been collecting for COVID-19. Before COVID-19, we talked a lot about equity. We talked a lot about which neighborhoods might need more support around infrastructure, which neighborhoods might need more bus lines. But one of the side benefits, for lack of better words, is that the COVID-19 data really illustrated the inequity of COVID-19, and it caused local officials and every other kind of official to really begin looking at neighborhoods and looking at communities and looking at who was being more impacted by public health, in this case, a public health crisis. So I would argue that there's a lot to have learned over the last several years from the data we've collected around COVID-19 in the areas of workforce, in the areas of infrastructure, in the areas of really a whole set of things with health. It's really touched all corners of our lives, even though it was just originally thought to be something that would monitor a particular virus. And so the question, I think, then becomes, how do we stabilize these systems and how do we integrate these systems and be able to actually use data in a meaningful way? And I think back to an example in my role in Los Angeles, one of the sort of opportunities that I was presented with was actually leading a large part of our COVID response for the city and preparing actually all the data and the research and much of the public health content in partnership with our public health agency. And I keenly remember when we began to really actually realize the impact that COVID was having on certain neighborhoods. And it became an important conversation. And I think we want to be sure that we can have those conversations and have the data infrastructure that will allow us to have those conversations as we begin to, again, move forward beyond COVID-19. I think my takeaway in all of this is really that the power of this data can help us provide better services in our government organizations when we strengthen our systems and we actually begin to think about this as so much more than just a public health crisis. And so with that, Lainie, I will turn it back to you. I'm really excited to hear what the experience of others has been. I think it is just, again, a pivotal moment in the public sector at every level. It's a pivotal moment in data. And I hope we can take the lessons that we've learned about really how this illustrates well-being in cities and be sure that we make choices that let us sustain all of the data that we've collected and begin to think about it with a new lens in all the different ways that it can now be utilized.
Thanks so much, Amanda. I think we're in for a great discussion over the next 45 minutes or so. I'm now going to turn to Mayor Greg Fischer, who will share his experience leading the city of Louisville through the pandemic and how he envisions enhanced data supporting future governance for local leaders. Mayor Fischer, over to you.
Thank you, Doc. It's good to be with everybody here today to talk about this important topic and especially what we learned and what we're going to do and how we're going to improve and continue to turn the improvement wheel here. So I became mayor of Louisville in 2011, and I recognized immediately that city governments had a lot to learn about leveraging data to improve our service to our residents. I'm a business guy, an entrepreneur that just happens to be mayor, and I would like to think I specialize as I got some experience in the business world and building high performance teams where data problem and solving problems and strategic planning were just critical to the success of any organization. So it was easy for me to see that whether it was how the city managed the process of paving streets or providing heating assistance or putting together the city budget, that there were opportunities to do more and to do better. Because my question was always, show me the data and how does this impact our customers or our citizens? Two basic questions. And we struggled sometimes at the beginning to answer those questions. But to effectuate that change, we created an office for performance improvement and an office for civic innovation. You've got to give dedicated resources to these two efforts. We created systems for identifying and tracking data and KPIs through an initiative that we called LouisStat after the initial CompStat models that the country had seen. And then I signed an executive order making the city's data open by default. And then, of course, we brought on a data officer and created an open data portal for the world to look into what we had going on here. Fast forward a few years, and all those processes are in place, making us certainly a more efficient, focused, and innovative team. And in 2020, Louisville became one of the first two cities to earn What Works Cities Platinum status, along with Los Angeles. So good job to my colleague on the panel here. And as much as I wish that was like the key story, the most notable event for 2020 in our city, history certainly tells us otherwise. And I will tell you that as COVID-19 proliferated in our communities far from Louisville and then closer and closer, I was relieved to know that we'd created the processes needed to leverage the data, create the teams that we needed to manage the impacts of the pandemic on our community. We built the muscle, in effect. But as you're well aware, COVID-19 was a challenge that would overwhelm practically any preparation, and it was an extraordinary event to really see how robust your systems are and then how quickly you could respond as well. But our gaps became immediately clear, including in the collection, analysis, and reporting of the data. Who's sick? Where are they? Who is responding? The difficulty, obviously, with COVID is you can't find an enemy that you can't see. But there we were hoping to contact trace with very limited test and fragmented data streams. And as mayor, I like to tell people when they're saying the way things should be, I say, look, mayor's in the reality business. And that means dealing with the problems that we can control and can't control. And back in March 2020, cities couldn't just order more tests. There just weren't enough to go around. And then soon after that, obviously, the pandemic wasn't the only issue that we were dealing with in cities. A recession, racial justice protests. It was a lot of chaos going on in 2020. So while we were prepared for the arrival of more tests, we worked to build on our relationships with our hospital systems typically rivals, but they worked in partnership with the seriousness that when the pandemic became very clear to us. And so think about that as a cross-functional team in a city, pulling together the hospital systems, the scientists, the social workers, the business community, everybody that could touch this problem and help us understand it at a deep level and then effectuate change. And so together, we created the structure and the processes needed to get and share pandemic data as quickly and efficiently as possible. Now, we have a strong public health team in Louisville. We're a merged city-county government, so fortunately, all falls under myself as the mayor and my team here. And so our public health team had already been tested during a hepatitis A outbreak a couple years before the pandemic, and their response was hailed as a gold standard by the CDC. So even before COVID, our health department knew the importance of data and transparency during a public health crisis. And so immediately, we stood up a public health dashboard and held daily media updates on the latest numbers. We set up incident command in our emergency operations center and attacked this like it was a natural disaster. And we got innovative support from partners as well. The University of Louisville started a Center for Enviromics a couple of years ago. So that's the relationship between humans and nature. They were one of the leaders in the country on sampling wastewater, so we could analyze where the virus was in our community. And obviously that's still helping us today as we're now looking out for any future variants. Also, long before the pandemic, about 17 years ago, Louisville was focused on racial equity. So we were one of the first city governments to establish a Center for Health Equity. And of course, data had already shown irrefutable and indefensible disparities in health outcomes over generations between communities of color and the white community here in Louisville and cities all over the country, with root causes traced to poverty, racist practices in employment, home ownership, and more. So we had a Center of Health Equity already focused on closing those gaps. So with this historical data in hand, we knew COVID-19 would be no different in regard to the potential for racial disparities. So we attacked that potential inequity with vigor. Our new data about positive cases is what guided our response, where we were offering testing, what and where we were providing community resources, later on vaccines. And this reliance on data to guide how we deployed resources equitably was the core of our vaccine response. And we needed to ensure that vaccines were available to everyone. And equity obviously means understanding that people in communities where poverty is prevalent or prejudice and might be prevalent or discrimination historically, there could be transportation needs. They may not be able to reach services during normal business hours. How are we going to overcome these obstacles? So using our data on vaccine distribution and relying on the wisdom of our vaccine distribution task force, that's the group of hospitals and scientists that I referred to earlier, we targeted neighborhoods with what we call LUVAX mobile clinics. So we took the vaccines immediately to the clinic disproportionately in areas that historically had disproportionately bad results. And I'm pleased to report that while challenge will remain for equitable outcomes in healthcare, Louisville has not suffered. We have not suffered the racial disparities that other communities have seen in COVID-19 infections and deaths. And there are a lot of people to thank for this, but I believe our city's intentionality and our use of data played a key role in this. So what's next? We're committed to continuing our mission of achieving health equity and improving the health and well-being of all residents and visitors. And we know that data will play a key role in COVID-19 and every other health challenge that we face. And challenges, as we all know, will persist, unfortunately. We still don't have a national public health data system. Each state has their own processes, and they are not fully compatible. That's a big concern for our city. We sit on a state line. The Ohio River divides Kentucky and Indiana, so we have a lot of cross-state traffic, but not a good way to track public health crises. There's a funding consideration for Congress. I hope they step up to it. We have plenty of public health challenges beyond COVID-19, including obesity and gun violence. And so we're going to continue to explore ways to leverage data to address them with equity in mind. And we're hopeful that this experience of a multi-year public health crisis will spur real investment in investing in infrastructure to collect, analyze, and report that data on a national, state, and local levels. So COVID-19 really proved the value of data when it comes to addressing a big challenge, and it brought data into our residents' living rooms with families discussing daily incidence rates, positivity rates, and just learning that, hey, science and data is cool. So that was a big breakthrough for our country. So I'm hopeful that our nation will learn from this experience and understand that we need more investment and more science and more data and great problem solving. Thank you.
Thanks so much, Mayor Fischer. It's a real pleasure to have you join us today. Next, we're going to hear from another expert with pandemic leadership experience, Dr. Sarah Kemble, who will speak about her experiences leading Hawaii's COVID-19 response and how data could improve future public health endeavors at the state level. And a big thank you to Dr. Kemble. As you can probably tell, for most of us, it is midday. It is very early in the morning for Dr. Kemble. Thank you so much for joining us. Over to you.
Thank you. It's an honor to be here today with this set of panelists. I'm really here to represent the State Health Department perspective in this pandemic and why we need to invest in data. In thinking back on the pandemic up to this point, there has been a huge evolution of data over time. And what I wanted to show here is our dashboard at the very beginning of the pandemic. This was as of April 2020 on the left. These were still at the time manually handmade epi curves that our team put together and posted on the website, trying to count community-associated COVID-19 cases that were reported to us. We realized very early on that the systems for reporting of communicable diseases were not timely at the local level or at the national level to try to compile this kind of real-time data sharing for the public. And so many health departments across the nation ended up creating this type of dashboard on their own websites. And at this point, even for national data compilation, whether it's CDC or our academic partners, most of the data is coming off of our websites. There wasn't a unified system in place that could handle that. At this point in time, we've had a lot of opportunity to add to our dashboard. So there's a lot more there now than was in the beginning, and that's shown here on the right. This is our epi curve as of yesterday. And there's also options now to download data sets from our website for public use, to explore the data and change the date ranges, to look at specific islands, and to choose different variables of interest. So it's come a long way. I just wanted to highlight for a moment, sitting in my chair as a state health department, the number of staff creating and maintaining daily dashboards as of March 18th, 2020 was 3. That state went on for longer than it should have, and people were working 24/7. Really, I had staff up at 4 in the morning trying to put the dashboards together for the day. We've now managed to expand that to 18 with the help of federal funding. But that's still a relatively small team for the work that's being done. A huge part of the pandemic response has rested on some of these existing technologies that we did have. Electronic laboratory reporting is a huge part of that. And it is an incredibly complex process. Again, I wanted to show the scale and the change in volume. So in January 2020, we had a total disease reporting volume of 8,548 for the month. January 2022, our best estimate was 274,635 reports in that month, although this is a gross underestimate because mid-January, our electronic disease surveillance system stopped being able to ingest negative results. And so we actually lost a number of negative results during this time period in order to make sure we could continue to accurately report on positives. The chart on the right just gives you a sense of, it's too small to read, but gives you a sense of how complex the electronic laboratory reporting process is. It depends on numerous external partners to go through their processes to collect and send data and go through standardization so that health departments can ingest it. We were fortunate in Hawaii to already have over 90% of our laboratory reporting captured electronically. So the transition for capturing COVID-19 was not as difficult as it might have been. And yet any glitch anywhere along that path can lead to delays in reporting and affect our public-facing dashboards. So I've started to talk about data challenges already, but some of the data challenges that we've faced as we think about collecting and sharing data, it starts right at the beginning. So some of the variables that we care most about to guide policy, such as race, ethnicity, industry, occupation, things that would tell us where pandemic impacts were being felt most strongly. These are very labor-intensive variables to collect. And we have done some of these through labor-intensive case investigation. Completeness and data quality has been a struggle as well. For hospitalization, if we're trying to link it directly at the person level to case outcomes, we only know that based on our investigation. So if we happen to call somebody on day 3 or 4 of illness and they aren't hospitalized yet, we may not learn of their hospitalization after that moment. Comorbidities are also incredibly challenging to collect in a complete and high quality way. And finally, getting information systems to talk to each other is another challenge. We have been very interested in breakthrough data throughout this pandemic, but in our state, we did not have a connection between our immunization registry and our electronic disease surveillance system. So this again was a manual process. So our focus ended up being on hospitalizations and deaths to try to get the best quality medical chart information we could and vaccine histories through manual investigation. The future is going to need to involve much more automation of these processes. One key point for Hawaii, because of our population and our location, was we realized early on that asking about specific race and ethnicity really does matter. This became something that was a high priority for us. We ended up hiring teams of investigators from local communities who could ask these questions in a culturally appropriate way and make sure that we were ascertaining specific race and ethnicity. And through that work, we ended up publishing this as an MMWR. This is just one illustration of that. The red circle here on this chart shows what you see if you ask about Native Hawaiian and Pacific Islander as an aggregate category. And in some states in the United States, that's also aggregated with Asian. So you may be asking, are you Asian, Native Hawaiian, or Pacific Islander? That gave a very different picture of the case rates per population than if we asked about being Native Hawaiian or Pacific Islander separately. And that's shown in the yellow here. But below that, even within the Pacific Islander category, we saw very different pandemic impacts at different times among Samoan, Tongan, Guamanian, Marshallese, and other Micronesian populations. So asking at that more detailed level really mattered. And this slide I share because it struck me during this pandemic that much as the mayor was just saying previous to this, pandemic data became part of our morning routine on the TV, on the radio, and our commute to work in a way that I had not experienced before. And I think this was surprising to many in public health. We aren't used to seeing our data from our dashboards on the freeway as we're commuting to work every morning. But it was something that became a part of the intervention. So actually knowing what the numbers were helped provide feedback to the public and did impact behaviors as we observed, so that when people were driving in seeing the 17.4% positivity rate, we actually began to see some changes in behavior around us, people wearing their masks more consistently or avoiding gatherings. And this is a lesson learned from this pandemic that I think we really need to carry forward and thinking about how the impact of data can itself be part of our public health intervention. There are obviously huge continued investment needs. One area is in workforce development. It's not just analyzing the data, but making sure our staff know how to communicate the data in a way that effectively communicates risk. Explaining risk can be very challenging. Modernizing information infrastructure is critical, not just to build the systems, but to maintain them as well. Standardization and automation are needed in many areas, and some of the hard-earned work we've done in areas like race and ethnicity, we need to look beyond that too, to see how do we redesign systems to address health equity in the very design of how we collect and transmit data. Data governance and sharing is also a key area. There is a balance and sometimes a struggle between public health authority and the responsibilities we have in handling confidential data with the right to information for the public and the impact that can have on pandemic response. We want data to drive public response. And then academic and community partnerships are another area to invest in. We need to build workforce pipelines and really focus on equity in all policies that look at how we engage actively with communities, not just during emergency times, but as a baseline that puts us in a more resilient place. So I will end there. Thank you for having me here.
Thanks so much, Sarah. I believe that our team has already cited your MMWR piece, and certainly no argument here about academic community partnerships. Lastly, I'm going to turn things over to Dr. Sean Truelove to discuss the role that COVID-19 vaccination data streams could play in supporting national and international vaccination efforts. Sean, over to you.
Hi. Thank you, everyone, for having me here. This is a really impressive group of people, and I'm going to be touching on, as you say, Lainie, the vaccination and how vaccination really drives a lot of our control and understanding of the pandemic and infectious diseases in general, and really taking a look at this from a broader lens of what we've been doing with modeling infectious diseases. So, as everyone has shown so far, this pandemic has really been essentially like an explosion of data. We have had more data on more things during this pandemic than any time in the past. And as an epidemiologist, that has allowed me to do things that I think previously we really weren't able to do with the specificity and the accuracy that we've been able to do. Everyone is very familiar with the COVID-19 dashboard at this point, telling us where we are in this pandemic, and what's the current status. But really, the work that we've been doing is trying to understand what's next, and we've been working with a lot of partners to really try to get a sense of what's going to happen, and in order to allow people to react and to make decisions and plan, from your state health department on control measures and vaccination programs to your healthcare systems on capacity and masks and PPE. This work really enables people to hopefully control a little bit of their lives during a pandemic. And what we really hope from this is that we can both be prepared for the next pandemic, but also extend this learning to other infectious diseases, right? We experience influenza every single year. Can we take some of the things that we've learned with COVID-19 to influenza or to other seasonal illnesses to better be prepared for those seasons, for those waves of infection and disease burden? And really, to answer a lot of this, we've developed, as many people, our own hub. And I think the hub or the dashboard has really hopefully been a thing that will continue, because I think what we've all learned is that the public is interested in these data, and the public is interested in understanding the situation around them in terms of and in the context of disease risk and burden, and really driving this understanding of the future are these many impressive data sets that so many people have put together, and dashboards that we all get to access. We have now understanding on how much control is happening around the world through things like the Our World in Data dashboard that gives us a stringency index. We've never had anything like that before. We have so much information now on vaccination coverage at such specific levels, thanks to the state health departments and the local health departments that have been collecting these data and now are providing them to the CDC, who now have systems to collate these data and aggregate and share these data with researchers and the public. We know about not just the coverage and doses across the country and across the world, but we know specific information on coverage among different age groups, among different races and ethnicities. And we know things about hesitancy from some of these surveys that have been done, like this Facebook survey and the Census Pulse survey. And these are tools and learning that we have developed throughout the course of this pandemic that have really enabled us to better understand what's happening in the context and what can happen in the future. And hopefully we can take some of this learning and some of these systems forward and continue them. And of course, as has been touched on, this will require funding and this will require interest and workforce capacity. But I think we now know the benefit of collecting these types of data. From some of our work, we were able to show really just the impact before it even happened, but the impact of implementing vaccination coverage or vaccination for children aged 5 to 11-year-olds. We were able to understand the impact of increasing or decreasing NPI coverage or NPI stringency, as well as increasing or decreasing vaccination coverage. And this enables state health departments, local health departments, and individuals to make decisions on their behavior, on their willingness to get vaccinated in the context of the potential consequences and the outcomes that can result from infection. These types of data will allow us to really hopefully enable people to prevent deaths and illnesses from other things in the future. We now have dashboards on variants, which I think is kind of a new concept for many of us. But now everybody in the world seems to understand the different variants that have been happening with the SARS-CoV-2 virus. And this has also led to some confusion, right? Why are certain variants emerging and causing substantially more impact than others? And so we have a ton of data, we have a ton of understanding now, but we also still have quite a bit to learn and quite a bit of challenges in this area. We need even more timely data than we already have. And really, so in the context of projection modeling and trying to understand the future, our ability to be successful has improved dramatically throughout this pandemic as the data has increased and the quality of the data has improved, as well as our understanding of the transmission and the context. But hopefully we can continue this. Unfortunately, I don't know that COVID-19 is completely gone from our world and our minds. So we will likely be continuing some existence with it. But there are other pathogens out there, and there are potentially future pandemics that we need to be prepared for. And so really, it comes back to this value of data. What's next? There are so many other data sets that are being developed: wastewater treatment surveillance or wastewater surveillance, behavior surveillance, things like that can really allow us to better understand the current context of disease and the future context and the future potential of disease, and really enable people, which now everyone is very interested in these data, really enable people to make decisions based on that and hopefully reduce the burden of disease in our world and our populations.
Thanks so much, Sean. I'm now going to turn to Q&A with all four of our panelists, and I do want to thank all of our viewers who are submitting questions. I see them coming in. Please continue to submit them over the course of this Q&A, and I am keeping an eye on those questions. So the first question that I'm going to pose to the group, and I'm going to give everyone a chance to answer. I think we should start with our government colleagues and then move to the academic folks. And this is an amalgam of several questions that have come in. Now that the numbers are a little bit lower, giving all of us perhaps just a moment to catch our breath. As you look towards the future, what are the types of data that you've learned are most critical, and what data do you wish you could have that you haven't been able to gather during the pandemic? And Mayor Fischer, I'm going to start with you and then turn to Sarah Kemble.
I would like to focus on the qualitative data. Why aren't people getting tests? Why aren't people getting vaccinated? The quantitative data is relatively solid, right? So want to get in front of all of that so that we can be more impactful once we've gotten 80% of the population vaccinated. So that requires a different level of intimacy in terms of citizen contact, whether it's in person or surveys. But that's what I would be focusing on here as we look at the next step here in Louisville.
Thanks, Mayor Fischer. And Sarah, same question to you. As you look to the future, what do you see as most critical in terms of data?
And I think my answer is very similar to Mayor Fischer's, except I'll add from my perspective, I also want to ask who exactly is not getting vaccinated so that we can then get to the why. For us in Hawaii, one point of frustration is while we've been able to disaggregate race and ethnicity for our case data through our case investigation processes, the vaccine data we receive is dependent on what we receive from providers and what gets entered into their system and transmitted to us. So we're still using the OMB categories, the aggregated categories for vaccine data. And we are able to drill down into geography of who's getting vaccinated in which areas of our state, which is a proxy, but it's not the same as actually understanding the self-identified race and ethnicity of those who were vaccinated or did not choose to be vaccinated. So that's an ongoing need. And that requires really working within information systems to understand how we're going to be able to collect complete and accurate data at the point of care and get that to filter through to public health to then be able to share with policymakers in a way that can drive action.
Thanks so much. And I'm now going to give my Hopkins colleagues a chance to answer the same question with a look towards the future. What data do you see as most important? And also, what do you wish you had that perhaps we don't have right now? Amanda, first to you and then to Sean.
Lainie, thanks so much. I think my sense is that as people begin more and more testing at home, an increase and better handle on positive and negative responses on at-home tests will be able to continue to give us just a really good picture of who and where COVID actually is happening. Some states, or some states and some communities have, a better handle on it than others. But I think that's as we go forward to the future, going to be something that is just a really big opportunity.
Thanks, Amanda. And Sean, could you please weigh in on this one?
Yeah. So I think we're moving toward a situation where states are scaling back their surveillance efforts. Local districts are scaling it back too. And so I think we need to think very carefully about how to implement a more sentinel surveillance program that is doable for everyone, but also effective. And as Amanda mentioned, we don't know a lot about cases and infections right now because of how much testing that's going on at home, and just how there's a lot of people getting infected who are not getting tested at all because there's so much built up in immunity in the population. So really effective sentinel surveillance systems that allow us to understand new variants that are emerging and coming into populations, allowing us to have a good handle on just how much transmission is occurring, but at a a reduced effort level will really be important and effective, I think, in the future.
Thanks, Sean. Another question that's coming in from several folks is for our government colleagues on the panel, and this concerns how you think about your data infrastructure going forward. So, Sarah and Mayor Fischer, in your opening remarks, you gave us a good sense of how these systems were built up from almost nothing to this robust presence that they are today. How do you think about this going forward, especially with an eye towards the next pandemic? You know, what's really sustainable in terms of this data infrastructure? Sarah, I'll start with you and then move to Mayor Fischer.
Sustainability is something we've had to think a lot about over the last 2 years as I've watched burnout and turnover among my staff. And for those who are continuing to plug away at it, it is almost a little alarming to us right now to be given pats on the back and say, okay, great job. Okay, what are we doing next? When we are still seeing the pandemic as a very real threat and not done yet. I think there is very much a need for sustained infrastructure, and that's both human infrastructure as well as continuing to build and then maintain the information systems that allow for this real-time data to flow. I think there have been points in the pandemic where daily data was a critical function. As I shared, sometimes that feedback loop really helps to drive public behavior. At the same time, policy decisions can't be made on a day-to-day basis. So in reality, it's the trends week by week that tend to be the most important. In weighing all of that in our existing resources, we did make that switch to weekly data reporting in Hawaii just a couple weeks ago. And I think that's an appropriate feedback loop at this moment, but it's something we'll have to continue to reevaluate.
Thanks, Sarah. And Mayor Fischer, same question to you from our viewers. How do you think about this public health data infrastructure moving forward and what's possible to maintain?
Yeah, well, I'm going to think about it in a proactive sense and a reactive sense in terms of where the investments are made. So like wastewater monitoring, for instance, obviously has become a lot more well recognized since the pandemic. So are we going to keep our investments going in that on a national basis? And it's helpful not just for the virus, but it's helpful for like PFAS levels in the water, other type of diseases that we could monitor. That's just a smart investment. So that helps us get ahead of some of these trends. And then as it relates to the data capturing for COVID as an example, it was challenging to set up the data collection process at the beginning. Data was not widely available. It certainly was not uniform. At the local level, it was difficult in terms of compatibility with the state, but we're in a much better process or shape now than we were before. So I won't say it's as, when you think about tackling a new problem, you look at it as innovation. Then you maybe go to a continuous improvement kind of level as you try to get it down to daily work. So we're at that daily work type of phase where I think it's important to kind of, what used to take hours now takes minutes. So to keep that type of capability in place while we have other more proactive measures in the community constantly sensing and a state and national network talking to each other that way.
Thanks, Mayor Fischer. Sean, question for you about the role of big data or AI modeling going forward. What do you see in the months or even years ahead here?
Yeah, we've learned a lot over the past 2 years. And I think there's a lot of interest in sustaining a lot of this work, at least for the near future, and really trying to sustain this as a continued practice so that we have people who are capable and systems that are ready for the next outbreak and the next pandemic potentially. I think there's a lot of lessons that have been learned and can continue to be learned from all of the data that have been generated. And a lot of us have been in such a response mode that we haven't had time to really do some of that research. So I think there will be a lot of work in that area in the next couple of years as well.
Thanks, Sean. And another question for our government colleagues, Sarah and Mayor Fischer, what can I say? You're very popular with our viewers. So they're hoping that you could give a little bit of a behind the scenes view on what happens with conversations or agreements between local governments or state governments as this pandemic is unfolding in terms of data sharing or trying to make data more uniform. How do those behind the scenes conversations unfold?
I'll jump in. Fortunately, we've got good alignment with our state government. So, unfortunately, as we all know, this disease, this virus was politicized in many states. So you had a lot of friction between local governments and state governments where there was not alignment of approach. So we did not have that. And so there was a maturity of our relationship that really allowed us then to share gaps in knowledge that we had and areas where the data was not making sense or aligning, or there could have been lags, there were blips, special causes. And so that relationship that we established very early on was really productively received by the state government, who had a higher level of maybe data analysis or data capture than we did from time to time. But it was really good. I mean, it's like when you're solving a problem, you're trying just to continuously turn the improvement wheel, the PDCA wheel. And that was happening a lot, and multiple times a day it would go on as well. But it took intentionality, and it took maturity on the state level, who sometimes sees themselves as a superior form of government, to understand that we really had our act together here with our local health department. A lot of health departments in the state and around the country were really not as ready for this as we were with our previous experience, as I mentioned before. So it was good, but it was a high contact sport, especially in the earlier days of the pandemic.
Understood. Thank you. And Sarah, I want to give you a chance to weigh in on this one too, if you're willing to pull back the curtain a little bit and give a behind the scenes view.
Yeah, I would also, having worked both at a local jurisdiction and now at a state jurisdiction, I've been on both sides of the coin, and definitely in Hawaii, because we have a centralized system, it's a little easier. We shared data freely with all of the counties and ended up being the primary data source for the counties in terms of case counts and metrics. I think the key, actually beyond even just the data, was getting together and communicating about the data together. So there were many, many meetings in rooms with the mayors, virtual rooms with the mayors and the governor and the Department of Health leadership to talk about what the data meant and how to interpret it and how to implement policies based upon it. I think one of the things I see as having been one of the successes of the pandemic in Hawaii was an early meeting in which a tier system was worked out that ended up being adopted by several of the counties within the state. That gave people a guidepost. So we're sharing the same numbers, but we're also then assigning different tiers or colors to those numbers to say, if you're in the red, this is what you should be doing. If you're in the yellow, this is what you should be doing. And this is what the state is expecting of you, or the county. And those systems, I think, gave people a sense of expectation and how to react that helped to stabilize things. And we didn't get cases to zero, but we had long swaths of time where we had a pretty low plateau and we were able to ride at that level. And I think that just helps to control the pandemic impacts.
Thanks so much. Well, we are coming up to our last minute or so together, so I'm going to make that the last word and wrap up. I want to thank all of our speakers again for joining us and for sharing their expertise. As I'm sure you could tell, their insights are critical, both for the current pandemic, but also as we try to anticipate future data needs and the opportunities to potentially repurpose COVID-19 data collection and then implement lessons that have been learned. The next Pandemic Data Initiative Expert Forum will be on May 6th at 12 p.m. You can pre-register for that event at the registration page for today's session or use the banner that you see below on the screen. Thank you to our audience for joining us. As always, this forum will be archived and available at coronavirus.jhu.edu. Until next time, thanks and stay safe.